Okay, good morning, good afternoon, and good evening, depending on which part of the world you are in. Welcome to what we hope is going to be the first of a series of monthly webinars organized by the WFNS Cerebrovascular Surgery Committee. I like to thank Himadullah, who has done a lot of work to make this possible and to connect us without any issue. Thank you, Imad. Please do, we have a great panel today. We will start with Dr. Vicent Quiles Quesada from Spain, who will give us an overview of the surgical and angiographic anatomy of the middle cerebral artery. Then Professor Carlos David from the US will give us an overview of some of the surgical principles and some tips and tricks in the surgery of middle cerebral artery aneurysms. And then Professor Peixi Liu from Fudan University, China, will give us an overview of some of the strategies to be utilized in the management of complex middle cerebral artery aneurysms. And my co-moderator and co-chairman of the WFNS committee, Michelle Bojanowski, will conclude the seminar and discuss a couple of cases. So without further ado, I'd like to pass the stage to Dr. Quiles Quesada, longtime friend and incredible neurosurgeon, who will give us an overview of the surgical and angiographic anatomy with these incredible slides and sections. Thank you, Vincent.
Thank you, Professor. Well, we are going to discuss part of the anatomy of brain and vessels, and also skull base and cisterns. But I would like to start giving my gratitude to the organizer of this webinar, especially to Professor Lancino. He's a good friend of mine, and I met him because of my mentors, Professor Evandro and Professor Christ. I met him in Arkansas years ago, and I would like to thank my mentors and Professor Lancino for all their support all over the years. Of course, I would like to give credit to my mentor who passed away, Professor Evandro de Oliveira. He was a great anatomist and also microneurosurgeon. And we were lucky to receive all his knowledge, and we are nowadays trying to spread his philosophy of laboratory dissection and work and anatomy learning before going to the OR and practice microneurosurgery in our patient. Also credits to my mentor, Professor Christ from Arkansas. And let's start talking about anatomy. Microneurosurgery and vascular microneurosurgery is about anatomy. It's the pillar of our work. So we all has to master this microsurgical anatomy before dealing with all this kind of pathologies. And pterional approach is the main approach to deal with this MCA aneurysm, and to expose not only the sylvian fissure, but also the cistern, the subarachnoidal space, where we will expose the carotid artery, carotid bifurcation, A1, M1, and then follow the MCA through the sylvian fissure. So if we come back to the beginning, and this is the lateral view of this in the skull, we talk about the pterional approach, and this is this region of confluence of this frontal, parietal, temporal, and sphenoidal bone. And this region is not a point, but a region related to the most anterior part of the lateral aspect of the sylvian fissure, the so-called posterior ramus of sylvian fissure. But also, we can also expose the most lateral part of the basal surface of the sylvian fissure, the so-called stem of the sylvian fissure. So once we open a craniotomy all around this terion, it depends how big we are going to expose, depending what kind of aneurysm and location of the aneurysm we are going to deal with. We will expose this most anterior part of sylvian fissure and also part of the basal surface of the brain. So this is terion, and we will decide what kind of terional approach. We see here superior temporal line, we see here temporal schema here. We see here we will have to drill this sphenoid wing to get a flat surface here, so to create enough window to work and reach the skull base and the basal systems, and then expose the anterior aspect of the sylvian fissure and open a highway to the basal system and the subarachnoidal space. This is a surgical view. This is the right side. And again, we have some landmarks, sphenoid bone here, temporal schema here, frontal lobe, bone, parietal bone, coronal suture here, superior temporal line. So Stephanion is here. We will expose here the inferior frontal gyrus if we open a craniotomy just below the superior temporal line. You see here again how the sphenoid wing is covering the lateral aspect of the stem of sylvian fissure. So if we want to expose this stem of the sylvian fissure and then open and expose the M1 segment of sylvian fissure, so we have to extensively drill all this bone and create a flat surface from this anterior fossa. We see here the roof of the orbit and the middle fossa and the most anterior part of the temporal lobe. When we expose and perform this terional approach, we are ready to dissect the sylvian fissure, the most anterior part of this posterior ramus, also dissect and open the stem of the sylvian fissure and expose all M1 segment, the genu of MCA, and posteriorly we can follow M2, M3, and M4 segments of MCA. You see here how we can create a highway to reach the basal system. So we will get proximal control while exposing the internal carotid artery or the carotid bifurcation on M1 proximal segment. And during surgery, we have to learn how to deal with the subarachnoidal space, and it is very important during performing vascular microneurosurgery to master cisternal anatomy and navigate inside systems. And suppose this is carotid system terional approach, we just expose internal carotid artery, we can get proximal control for different anterior circulation aneurysms. We can move medially. This is optic nerve Cayam's lamina terminalis. We proceed to the lamina terminalis system. This is ACOM complex, A1 and 2, anterior communicating. And then we will move laterally to the stem of sylvian fissure and then start following the system of the sylvian fissure to expose the anatomy of the MCA. Excuse me. So we will get access through the sylvian fissure to the basal systems and then get proximal control and then totally expose laterally the anatomy of MCA and one segment, genu, all around the pole of the insula, and then follow M2 segments running over the cortex of the insula, M3 segment opercular, and then superficial or segments of MCA, M4 segments. And again, everything is about anatomy. This is a lateral view of the sylvian fissure, the so-called posterior ramus of the sylvian fissure. So we have, this is left side, this temporal lobe, frontal lobe, parietal lobe, and then we can move and get an inferior anterior view of the brain. So we have here the temporal pole. So we see here superior, middle, and inferior temporal gyri and temporal pole. This is the base of the frontal lobe, so the orbital gyri. This is the uncus, mediovascular temporal region, and this is carotid artery. So carotid system, and again, optic nerve. So we see here M1 segment of the MCA wall opening the stem of the sylvian fissure. You see how the stem of the sylvian fissure is projected towards the base of the brain. And once we open the stem of the sylvian fissure, we can totally expose the M1 segment of MCA. And we can divide this segment in two parts. The proximal part related to the uncus anteriorly and to the anterior perforated substance, and the distal part related to the anterior surface of the insula. This is the anterior operculoinsular compartment, and we will see here some early branches, temporal or frontal early branches, some branches looping in this anterior operculoinsular compartment, and related to the most proximal segment, and also the distal one, we have to be aware of these lenticular-striate arteries running toward the anterior perforated substance. Once we move laterally toward this anterior operculoinsular compartment, aneurysm located in this location will be related to the planum polare. We see here this concave surface and early branches at this level, and then we will be facing the genu of the MCA running all around the insular pole, and then giving access to the M2 segments of MCA. We see here the anterior surface of the insula, so the anterior operculoinsular compartment, and we will see how, when studying the angiography, we will be able to identify these branches looping in this fissure. So we will be ready to identify the location of different M1 aneurysms or aneurysms in relation to this MCA bifurcation of the genu of the MCA. Then we will not retract to identify the relation of this superior temporal gyrus and the base of the frontal lobe, so the posterior orbital gyrus here. And then if we move laterally and we open this posterior ramus of sylvian fissure, it becomes easier to expose this anterior part, and this is the part related to the pterion. While opening a window just at the level of pterion, we will expose this anterior sylvian point, so the apex of the insula, close to the genu of the MCA and the proximal segments of MCA, M2 segments, and the cortex of the insula. And this is the edge of the insula, so superiorly we will have the superior lateral operculoinsular compartment, and inferiorly the inferolateral operculoinsular compartment. And mostly the MCA branches, M2 branches, will be running in this inferior operculoinsular compartment, the main branches of MCA. If we move posteriorly, we see here the Heschel gyrus. So anteriorly we have the planum polare, posteriorly the planum temporale. We see how narrow is this distal part of the sylvian fissure. We sometimes have distal aneurysm of MCA, and so it is more difficult to access in these deep compartments of distal branches of MCA. And we will expose the posterior aspect of the insular cortex. And this is the most posterior part of sylvian fissure, so the distal segments of M2 branches and M3 branches running over the operculum, and 4 branches on the surface of the lateral surface of the brain. This is a 3D volume, kind of a virtual reality model of the sylvian fissure totally open. And this is a lateral view, so we can identify the anterior, superior, and inferior limiting sulcus of the insula. We see this kind of pyramidal shape of the insula, and this is the apex of the insula. Superolaterally, the superior lateral operculoinsular compartment, inferior lateral operculoinsular compartment, and then anterior surface of the insula, so the anterior operculoinsular compartment of the Sylvian fissure. We see how it is related to this distal aspect of M1 segment of MCA, and we have here the proximal aspect of this M1 segment in relation to the uncus and the posterior medial orbital lobule. Just to focus a little bit and identify this anatomy and the different conformation of the artery all around this the fissure and the surface of the brain, and it will be important to be able to identify to understand the geography that we are going to study later on. This is a superolateral view, superolateral operculoinsular compartment, inferolateral operculoinsular compartment, upper surface of the temporal lobe, so planum polare, hysiogyrus, planum temporale, and the narrow space in this most distal part. We can then turn and get a more surgical view. And remember, once we open the pterional craniotomy, we will get access to this stem of the Sylvian fissure, and we now realize how it is related to the base of the brain. So we can focus and expose M1 segment. Most of MCA aneurysms will be located in this M1 segment distal part or genu of MCA and MCA bifurcation. This is basal surface of the frontal lobe, the olfactory nerve and tract. And this is the correlation with surgery. So once we perform a pterional approach, we expose this basal surface. We see here the stem of Sylvian fissure. This is the anterior Sylvian point, pars triangularis, pars orbitalis, pars opercularis. So it's a part where the arachnoidal space widens. So we will usually start opening the Sylvian fissure at this point. So expose the apex of the insula, usually MCA bifurcation, and totally expose M1 segment towards the carotid bifurcation here, A1, deep inside, and internal carotid artery. And once we master the anatomy of the brain and the anatomy of arteries and vein, we will be ready to understand the angiography and correlate the angiography with brain anatomy and totally understand the three-dimensional anatomy of the pathology that we are going to deal with in the OR. Nowadays, we have excellent radiological studies. This is an MRI, sagittal CAD midline, so we can identify all sulci and gyri of the brain, and we can exactly correlate this anatomy with the brains that we can dissect in the OR with arteries and veins injected. And when we have this AP view of the angiography, we have, like my mentor, Professor Evandro, used to say, we have like the skeleton of the brain. So we have to be able to reconstruct the volume of the brain all around the skeleton, all around the arteries and veins of the brain. So we have here a standard AP view of a right side angiography, and it is easy to try to correlate with a right side anterior view of the hemisphere. So we have the frontal lobe here, parietal lobe, Sylvian fissure, temporal pole, the stem of the Sylvian fissure, so the basal surface, and we can imagine how carotid system is here, will bifurcate towards the anterior cerebral artery, and laterally MCA running deep inside the Sylvian fissure. But we have to be able to follow these arteries deep inside the Sylvian fissure, deep inside the interhemispheric fissure, and correlate its anatomy with the surface of the brain, the sulci, gyri, and even central core, or the anatomy of the insula related to this MCA anatomy. Again, Sylvian fissure, anterior view, we just remove the frontal lobe in the coronal cat, and we can follow also anterior cerebral artery deep inside the interhemispheric fissure. So if we follow the artery, this is internal carotid artery coming from the neck, petrosal segment, cavernous segment, supracrinoid internal carotid artery, carotid bifurcation. Medially, we have A1 segment, and then this is the ACOM complex, and then we follow distal segments of anterior cerebral artery deep inside interhemispheric fissure. So we can imagine here midline, the folds, and in relation to the anterior communicating artery, we can imagine the lamina terminalis cistern, chiasm, optic nerve. Laterally, we have M1 segment of MCA. Remember, we just saw how this proximal part is related to the uncus of the temporal lobe, so we can imagine here the uncus. And superiorly, we have the anterior perforated substance, so we can see lenticular striate arteries entering the anterior perforated substance and just feeding central core and basal ganglia deep inside the brain. Distal segment of this M1 MCA. Now we are related to the anterior operculoinsular compartment. We see this anterior surface of the insula and the insular apex here, and some arteries are looping deep inside the anterior operculoinsular compartment towards the anterior limiting sulcus of the insula. So we will have sometimes aneurysms here, pointing up, facing the anterior surface of the insula, and pointing down towards the planum polare of the temporal lobe. And we see here M3 branches running over the surface, this upper surface of the temporal lobe, and then M4 branches in this lateral surface of the temporal lobe. So we can totally imagine and recreate the anatomy of the temporal lobe, central core, cortex of the insula, and we see here M2 branches running over this cortex of the insula, and then planum temporale. We see here straight distal branches of MCA, M3 segments of MCA running straight deep inside this narrow compartment of the planum temporale. So now we are able to reconstruct in our brains all this anatomy and follow the arteries and reconstruct the deepest part of the Sylvian fissure and the surface of the temporal lobe, insula, frontal, parietal, operculum, and totally reconstruct the lateral aspect of this AP view of the angina. This is contralateral side, again, internal carotid artery, carotid bifurcation, A1. ACOM complex, remember, we expose this complex through a trigonal approach, so we have A2 branches. It is located in relation to the lamina terminalis cistern and above lamina terminalis, optic nerve, optic chiasm. We see here lenticular striate arteries, so we can imagine the central core and we can imagine the location of the basal ganglia, and laterally covering the central core, the surface of the insula. So we see here M2 branches running over the surface of this insula, and we can start to reconstruct the deepest part of the brain, central core, basal ganglia. We see anterior perforated substance here, lenticular striate arteries, carotid bifurcation, medially, A1, ACOM complex, optic nerve, lamina terminalis, and then distally interhemispheric fissure. Laterally, we will have the ventricles, and inside the ventricle, we will see an empty compartment of this angiogram. We will see a blind spot. There are not too much vessels and arteries deep inside, so we can imagine the location of the lateral ventricle of the brain here. Again, if we follow MCA, M1 segment, M2 segment, genu, and temporal lobe, temporal pole, and cortex of the insula. So we can even totally reconstruct the anatomy of the central core and imagine following the ventricle, following the central core, the insula, totally reconstruct even the location of the choroidal fissure, midline structures, atrium in relation to the most deepest part of this planum temporale, well, the Herschel gyrus is projecting to this retroinsular compartment, and we will identify the last deep loop of this MCA, the so-called endpoint of this angiography, pointing to this atrium on the retroinsular compartment. So we can totally reconstruct the anatomy of the brain. Now, lateral view. Again, same exercise. We can imagine the lateral view of the brain, and we see here the internal carotid artery, cervical, petrous, cavernous carotid artery. We see here ophthalmic artery, so the orbit is here. Then we have a lot of arteries here in this same 2D plane that we can identify the distal branches of anterior cerebral artery, just running all over the corpus callosum. And then we will be able to identify this Sylvian triangle, the M2 branches of the MCA laterally. So we can differentiate a lateral aspect of this lateral view of the angiography and a medial aspect, interhemispheric aspect of this anterior cerebral artery. Of course, a lateral view, it's easy to correlate. We can imagine Sylvian fissure here, and we see how opening here, the Sylvian fissure, we will get access to the internal carotid artery, paraclinical aneurysm, proximal aneurysm of this internal carotid artery. But we can also follow this anatomy, and knowing how the pericallosal and callosal marginal arteries are running following the corpus callosum sulcus and the cingulate sulcus, and in between we have the cingulum, we can imagine and reconstruct the location of below the corpus callosum, the ventricle, and in relation to this Sylvian triangle that we see here, a triangle, so anterior, superior, and inferior limiting sulcus of the insula, and M2 branches covering the surface of the lateral surface of the insula. We can imagine the location of the insula, so insula covering the central core, and the location of the lateral ventricles or around the central core. And again, if you pay attention, we have not too much vessel all around the Sylvian triangle and the limiting sulcus of the insula. So it is easy to locate the ventricle in between central core and the inferior aspect of these pericallosal arteries, and then reconstruct the corpus callosum as the roof of the lateral ventricle, sulcus of corpus callosum, so deep inside interhemispheric fissure, we can follow pericallosal artery, callosal marginal artery, in between both the cingulate gyrus, and then follow this gyrus posteriorly. We can even follow the distal branches of anterior cerebral artery, and we will realize how at the end we have like the marginal ramus of the cingulate sulcus. So we will identify more or less the location of the paracentral lobule. You know that marginal ramus of cingulate sulcus is related to the posterior aspect of this paracentral lobule. So it is related to the central sulcus, correlated to the lateral surface. So we can start to reconstruct the lateral surface, central sulcus, and we know how this central lobe, precentral and postcentral gyrus are running from this paracentral lobule laterally, covering the splenium and posterior aspect of the body of the corpus callosum, as we see here, and then we'll cover the posterior part of this superolateral operculoinsular compartment. So we have here precentral, postcentral gyrus covering this and superior and posterior aspect of Sylvian fissure. Then, of course, temporal lobe will cover this inferior lateral compartment, and we see here the insular edge. And now we are missing just pars orbitalis covering the orbit, and we see here distal branches of ophthalmic artery, pars orbitalis, pars triangularis facing the apex of the insula, and pars opercularis connecting to precentral gyrus. So we totally reconstruct the anatomy from the deep compartments of the brain, following the arteries inside the systems and fissure towards the lateral aspect, and then recreate the three-dimensional volume of the brain. So that's the exercise that we do. And this is an example of an M1 MCA aneurysm. This is a superior projecting M1 MCA aneurysm. And we see how this aneurysm is located in between these proximal segments, so uncus here, anterior perforated substance here, and how the artery is just running following the anatomy of the insular pole. And in the midpoint in between this proximal and distal part, we will find this aneurysm projecting towards the central core, projecting towards the basal ganglia of the brain. And this is the stereonal approach. This is a stem of Sylvian fissure. We already released some CSF. We just dissect the stem of the Sylvian fissure, so we have a view of the basal surface of the brain. We follow the stem towards the lateral surface, and we will totally expose the M1 segment of the MCA deep inside this stem of the Sylvian fissure. This is the proximal part, so we are now facing the most proximal aspect of the Sylvian fissure. So we see here the uncus lateral is left side, and internal carotid artery and one proximal segment. This is uncus, upper surface of the uncus, carotid bifurcation here, A1 running towards the lamina terminalis system. We have proximal control at this level. We can move posteriorly, and this is it looks like an aneurysm, but it is actually the genu of MCA. It's a big artery and genu calcified. And then in between this proximal part segment and the distal, we see the neck of the aneurysm partially calcified, and an early frontal branch here running towards the frontal lobe. We have a proximal control here. We have the neck of the aneurysm. We have a posterior part of the aspect of the neck. So we totally expose this anatomy. And we start with a pilot clip. We are worried about lenticular striate arteries because these aneurysms are related to this lenticular striate arteries. So we, of course, have to keep patency of this branch. We have to explore lenticular striate arteries to avoid clipping any lenticular striate artery that we see here. This was the pilot clip, just to stretch a little bit the aneurysm. We identify some lenticular striate arteries, so we have to now move the clip. You see here how the clip is clipping the lenticular striate artery. We are now going to change the direction of the clip in this posterior part of the neck of the aneurysm, and then we will check the anterior part, so we will avoid any other lenticular striate arteries related or clipped by our clip. Again, we change and we keep patency of the artery. We see here other lenticular striate arteries here. We check the patency with the Doppler, and now we are going to complete clipping with a small clip at this calcified part of the neck. So now, once we finish, we check how we the patency of the arteries, how we exclude the aneurysm, and how we keep. You see here lenticular striate arteries at this level. We exclude the aneurysm, and once we can see lenticular striate arteries, patency, the anterior one, and the one that was clipped at the beginning here, the most inferior part of the neck. This is the final result, and one segment, uncus, orbital gyri, and totally expose this M1 segment. This is the post-op angio CT showing how we exclude the aneurysm. And I would like to finish with some words of my mentors. These are some words from Professor Chris.
The answer is have to be prepared. How do you get prepared? You commit long term. You do the homework. You go to the lab. You go watch people who are doing it. You have to dedicate the time. Is it worth it? Is it convenient? It's worth it, yes. Is it convenient? It's convenient for your patients. It may not be convenient for you. That's where the fight is.
And finally, some words from Professor Evandro on how we have to face our practice.
If you don't know what you do, forget it. Never you reach the point. Never.
That's something we learned from Professor Evandro. We have to love what we do, and we need passion for our work to not only master anatomical knowledge and microsurgical techniques, but we have to achieve excellence. And excellence is about passion and enjoy the art of microneurosurgery. Thank you. Thank you very much.
Thank you, Vincent. Great overview as usual, and tribute to our dear friend and teacher Evandro de Oliveira, and how beautifully you are continuing his legacy. I also appreciated the very important point that you made, in addition to many others, but in terms of the surgical anatomy, the relationship of these M1 aneurysms to perforating vessels to the lenticulostriate arteries. They can be very tricky, and you show it very nice. And that's for the young colleague, a very, very important point to remember. When you see those proximal M1 aneurysms, often related to an early frontal or temporal branch, always be aware of their relationships with tiny lenticulostriate artery vessels. After this beautiful anatomical overview, if you can stop sharing, Vincent,
Yeah.
I like to give the stage to Carlos David, great friend, incredible educator, very, very skilled neurosurgeon with a lot of experience, not only in vascular neurosurgery, but with many other complex neurosurgical problems, and very grateful and honored that he's here with us today. And he will give us his overview, sort of like how I do it, how I think about middle cerebral artery aneurysms. Carlos, thank you so much.
Thanks, Giuseppe. Real honor to be here, and tough to follow Vicente on that. That was just a beautiful presentation. And in fact, I'm going to be able to skip over a bunch of my slides now because he's really covered it better than I could. So, I'm borrowing from a talk that I prepared a while ago. It was more of a debate talk, and I call it the middle cerebral artery aneurysms, the last bastion. And Giuseppe and I have had these conversations over and over again. And, the reality is that microsurgery is decreasing. And for me, as an educator, I have a large concern that my residents graduating today are not comfortable with a lot of this type of work compared to our generation when we graduated. The volume is just not there for them to learn on. Most aneurysms today are being treated from an endovascular standpoint. And for a long time, the middle cerebral seemed to be the last holdout for the microsurgeon, although that's starting to change as well. Just some disclosures that have nothing to do with this today. As Giuseppe knows, I love history, so I always like to go back because our specialty is actually very young. And if you just go back 80 years, this is really striking when you think about where we are today, what Vicente just showed. When in 1944, Dandy reports on 64 MCA aneurysms, 100% mortality, and the conclusion was that it had a poor surgical future. Just put that in perspective as to where we are today. It really is amazing, given how young our specialty really is. So, then there's more history. We can go, I'm not going to belabor all of this, but, for the younger neurosurgeons out there, you really go back and look at your history. It's amazing what these giants accomplished and how we really stand on everything they worked out. And you can see here how the gradual improvements, little incremental steps that led us to, the modern era where Professor Yassergil really showed us how to dissect that fissure, how to understand the cisterns and the base, the base of the brain, and Drake and Peerless in London, Ontario, showing their version of things, mostly in the posterior circulation, but discussing the different ways of splitting a fissure, the proximal to distal versus distal to proximal. Wilson and Spetzler initially, when Spetzler was a resident, they proposed the proximal to distal. Then later on, it was more of a distal. Dr. Harrows through the gyrus rectus and just all the different arguments. And it's an interesting history they should be aware of. So, when we look at MCA aneurysms, just the standard epidemiology, they are, when we look at all aneurysms, fairly common. In most series, it's around 20%. Autopsy series can be as high as 40%. Some data suggests that the rate of rupture is actually lower in this location than other locations. Hence the propensity for giant aneurysms to form in this part of the circulation. But in general, it's something that we're going to commonly see among aneurysms. And I'm not going to belabor this. We all know this data. The larger the aneurysm, the higher the risk. But in general, most small aneurysms have a very low risk of rupture. And the natural history is benign unless you're unlucky enough to be in that small percentage. And the way I tell my patients, I think of it as being on an airplane. The chances are everything's going to be okay, but if something goes wrong, it's going to be really bad. So the anatomy, I'm not going to belabor this. This was already presented much better than I. The points I want to make are, again, these different segments. And something that I always stress for my residents is when you're preparing to deal with an MCA, you really have to look at the length and the course of your M1. Is it concave towards the brain or convex? Is it short? Is it long? Because this will prepare you for what you're going to deal with inside. So if it's a short M1, it predicts that your lenticular striates are going to be near the bifurcation. They're going to be near the area that you're working on. In these situations, you don't need to split the fissure from very distal to proximal. You just need to stay proximal. The course, does it loop towards the brain or away from the brain, will tell you, how am I going to get my proximal control? If it has a very convex course, you can get proximal control underneath. And again, knowing where those striates are going to be prepares you ahead of time before you're there. So these are things that I always look at. And again, this is the location of the aneurysms. We already talked about this, so I'm going to skip through some of this to kind of move ahead. How do we manage these? Obviously, we're talking about microsurgical clipping this morning, but let's not forget that there is more and more endovascular treatment of these types of aneurysms. Whether that's good or bad, we can debate that. I don't think coiling works well. I think everyone accepts that. But now we have the web devices and so forth. The data, in my opinion, is not convincing, and they can spin it however they want. I'm not impressed at this point. Most of the data suggests that it's only 50 to 60% complete occlusion. Time will tell, but I still think this is an aneurysm that is surgical. But we can't forget that sometimes these aneurysms are not clippable. And in those situations, we have to think about occlusion, trapping, bypass, and be prepared for that. And of course, sometimes it's maybe best to leave things completely alone. Again, so what I think about and what I try to teach my residents ahead of time, we look at that angiogram and we try to visualize exactly what Vicente just showed us. And what is the length of that M1? Where is the actual bifurcation? And is it a bifurcation or a trifurcation? Where is the aneurysm? What is its projection? Is it pointing superiorly into the frontal lobe? Is it going into the temporal lobe? All of this is going to guide how you split your fissure, how you get your proximal control, and what to anticipate in terms of perforators that could be injured. And again, look at calcification in the dome or neck. These aneurysms tend to have that, and you have to be aware of that in terms of your clipping. And then again, its relationship to the sphenoid wing. Again, I can't do this as well as Vicent just did, so I'm not going to belabor it. The terional approach is the workhorse. The only times I would consider adding an orbital cranial in these situations are for the very large, giant aneurysms, where sometimes it's difficult to see around the aneurysm towards the carotid and the proximal circulation. So in those situations, adding that gives you a broader, wider point of view, gives you multiple angles to move around the aneurysm and see it from every vantage point. But for the most part, the standard terional, mini terional, whichever version you like, is going to be enough. In terms of positioning, most of these I do 30 to 45 degree head turn, 15 degree off the horizontal plane so the brain falls away. A very aggressive drilling of the wing. I really like to see the periorbita at the meningoorbital fold. That tells me I'm low enough so that I have a very flat, smooth approach to the base. I always preserve one of the branches of the STA because you just never know when you're going to need to do a bypass in these situations. This is standard Yassergill teaching, the interfascial approach. I'm not going to belabor this. I basically, for my residents, I teach them, you don't have to go to the extent of dissecting all this out. If you stay a finger breadth above this region here, you'll avoid it and you just move on with the operation. And again, drilling that wing, removing this to the point where I see the fold of the periorbita at the meningoorbital fold. That to me is how far I want to go. I really want an aggressive wing removal. And then splitting the fissure, again, this was covered. There are many ways of doing this, proximal to distal, distal to proximal. I split what I need. I try to do just what I need for the specific case. I try to teach and envision that the cistern is actually a balloon. There's going to be the outer layers and then the inner layer. The vessel is traveling through this. And as Yassergill teaches us, my goal is to get inside, get deep, follow the M3 to the M2, the M2 to the M1, and then open it from deep to superficial. I love his analogy of opening an orange from inside out rather than outside in. I think it makes perfect sense. And again, this is kind of those basic principles, staying on the frontal side of the veins, deepening your dissection, and getting down there. And just to kind of show an example, I start distal. This is the left side. I start distal, open the thick arachnoid until I'm sure of where I am. I'm just going to move this forward a little bit. And then start those thicker outer layers until I'm inside, and then I follow those branches downward. And once I'm inside the fissure, opening the superficial layers, but then I'll follow it around the course, get to that point. Now from deep to superficial, and then that shows you what needs to be cut. Because frequently this area near the limen is where the opercula can kind of fused with the temporal lobe. They don't always separate nicely. And if you go very deep and come superficial, you'll get to the point where you'll see where the fissure is actually meandering. For the uninitiated, you need to think about how the fissure is going to course. It may loop back and forth. It doesn't always follow a straight trajectory. So you have to, don't envision in your brain and connect dots that aren't there. Follow it by following the vessels. Temporary occlusion, I think, is very important for these types of aneurysms. I'm a very liberal user of temporary artery occlusion. This is a very old study. It came out when I was a resident, but I think the numbers still hold today. Bacher and Sampson's series really showed us that there are limits to this, and you have to use cerebral protection. I think up to 30 minutes on an MCA with cerebral protection will be okay. I tend to take it off after a few minutes if I'm going to be prolonged to kind of reperfuse the brain. But avoid, again, where you put it on, avoid the perforators being included in the arrested circulation. Always try to be distal to them. Keep the blood pressure high and stay, again, within the safe occlusion times. So the temporary clip application, this is what I was referring to in terms of the course of the vessel. If the vessel takes a very concave loop towards the brain, remember your vantage point is coming in this way. Your proximal control is very easy. It's going to be underneath the aneurysm, away from you. This is very preferable. And this is the situation that you see there. That basically the M1 is coming up into your face. Whereas when it's more of a straight or the opposite direction, now you have to go around the aneurysm to get your M1 and your proximal control. And that's where having a very good wing drill down is important. And in a very large aneurysm, this is where taking maybe the orbital cranial part gives you that advantage to look in front. So again, this is kind of just two examples. Here's one where it loops underneath. And so you can see I have my proximal control underneath everything. It's a beautiful situation. This is my favorite situation because I don't have to worry about this clip being in my way when I'm now going to dissect out the aneurysm. Versus the opposite situation where here I have a giant aneurysm, I have to go around the top of it. So there I needed much more proximal exposure of the wing and so forth. Then the actual dissection. Again, you have to be cognizant of the different projections, where the perforator is going to be aware of that you may kink the origin. You want circumferential dissection. I have never regretted ever seeing the aneurysm completely. So I really belabor this point. My clipping scheme is going to always be parallel to the origin of the vessels, and I'll get into that in a moment. But the most important thing is to really see the perforators, understand the anatomy, understand is there any calcification, is there any atheroma on the neck that may create a problem for you. Sometimes the aneurysm is large. You can put a temporary clip on and shrink it with bipolar, as Dr. Yasuko showed us. Pilot clipping, again, another wonderful technique that excludes the more dangerous part of the aneurysm, allows you to mobilize it, see it completely. And I'll show an example of that. And then the clipping schemes. So one of the things I like my residents to do is study those charts that the companies put out with all the different clips on it. Start memorizing all the shapes. Understand what is in your armamentarium ahead of time. And then understand that this is a three-dimensional puzzle and you're trying to reconstruct preserving flow and preserving the origin and the axis in such a way that you're not going to kink or compromise the flow. There are times where you need to open the aneurysm, do a thrombectomy, remove some of the atheroma. You know, an aneurysm like this at first looks like this is completely unclippable, and it turned out that it was very clippable. So it's just a matter of understanding that situation. And this is study the various, papers that are out there that show the various techniques and schemes. Every one of these is a geometric puzzle, and the more of them you've seen, it's almost like a chess game, the better you visualize what you have to do. And remember clipping, and my friend Ali Krish that was mentioned earlier, he loves to stress that clipping is not just throw the clip on, it's an actual process. And you use the blades themselves like a dissector with your sucker, maneuvering, pulling the aneurysm in order to put it precisely where you want it. This is the kind of diagrams that you should look and study and keep in your mind. So you have all these different variations that may come up, specifically in this location, to reconstruct the aneurysm. There are endless ways of doing this, and I think you just have to kind of keep these in mind so that you can reconstruct what is appropriate at that time. And these papers are out there, and they, rarely is it just a simple one clip. Many times in this location, you have to do some type of geometric puzzle reconstruction. So here's just a simple aneurysm, but I use it to kind of make a point. So splitting the fissure, getting down to the aneurysm. And this aneurysm basically was one of those I'm talking about where the proximal control was underneath. Okay, let me just get down to it. So I have my proximal control underneath, and it's adherent to the temporal lobe, and there's a branch here. It's a fragile aneurysm. It's ugly. The temptation would be to just put a clip across it at 90 degrees, and that would potentially compromise the flow. So I put a pilot clip on, and that allows me now to finish dissecting it without incurring a rupture. I can get it off the temporal lobe, get it off that branch. I'm going to just speed this up. And now I have a view, and now I can reposition my proper clip in that plane of the M2s. Going at 90 degrees would potentially risk kinking the origin. So flipping it 90 degrees reconstructs it the way you want. And this one had some atheroma down here that was preventing the clip blade from landing completely. And again, checking your flow, readjusting, fighting the balance between the atheroma, where I could get the clip, and again, not being devoted slavishly to the perfect clipping, but trying to achieve as much as I can in this situation. And you'll see I keep working it until I'm completely happy with the reconstruction. And finally, I had to leave that little bit of atheroma, and I put a second little clip just to kind of reinforce that area. Sometimes aneurysms are just too complex, too thick-walled. There's a thrombus. The clips will slip and slide down, and you're forced to open it and kind of remove some of this to create room. So here's an example of one of these. This was a giant aneurysm presented with seizures and mass effect, left-sided, opening the fissure. And here you see M1, M2, M2, and I'm checking flow ahead of time. I want to know what those numbers were. I do my ECG ahead of time before I do anything. And here is this giant mass of an aneurysm. So here's one where you have to open it. And I do not put temporary clips on at this point. I want it to have back pressure, whatever there is of back pressure, until I see that. Once I see the bleeding, that will help keep the thrombus from milking its way up into the M2s. And then using the ultrasonic aspirator and endarterectomizing, trimming it away, and gradually cleaning this up until then it becomes the geometric puzzle. And that giant complex aneurysm actually turned out to be relatively simple in terms of getting it clipped properly. And so all of that is gone. Now I'm going to remove the actual mass in the frontal lobe of this giant aneurysm. You can see how large this was, filled with all this atheroma, cutting it away. And then at the end, you'll see here, this is what it turned into, just 3 clips, that big giant aneurysm. So you can never really understand what you're going to deal with until you're there. But those were the steps that I followed here to avoid getting into trouble. What about situations like this? What are you going to do? Frequently, you're going to have to trap and bypass. It's unlikely you can get away with just pure Hunterian ligation on the middle cerebral artery. So you have to be prepared. And this is why I always preserve the STA on my way in. There are times like this where the aneurysm is such and the vessels are begging to be just put back together, but that's less common. So, situations like this, the MCA is an area where we tend to see dissecting aneurysms. And what are you going to do with these type of situations? Here, you're forced to bypass distal occlude, proximal occlude, trap. There's variations on it. The point is to kind of create a flow reversal. So here's a patient of mine that I saw a few years ago before leaving Boston, who presented with this horrible sausage aneurysm. What are you going to do with this? There's nothing you can do here except I did a bypass distally and went ahead and trapped. And luckily, and I'm not going to belabor this is just showing the bypass. But at the end, it turned into just an STA MCA. I have my bypass. And then at this point, it became a matter of just trapping that segment. What about a situation like this? Here's a grade 3 subarachnoid hemorrhage. This branch is coming out of here. This branch is coming out of here. And this is there. There's no way to clip reconstruct this. So in this situation, I was forced to do a double barrel bypass and then occlude right at the entry and trap the aneurysm. And unfortunately, there were some striates that were coming off one of those branches. It was just unavoidable to exclude that. And so I did the double barrel bypass, but he still ended up with a small infarct and took a long time to recover. So that sometimes these situations are bad. So here, now what do we do with this? This is something you always have to be prepared for. It's one of my favorite parts. So this is a video. When I was a first-year resident, one of my chiefs was doing his first aneurysm with an attending who probably should not be clipping aneurysms. And I love this video. I kept it all these years because it really shows how bad things can get and how when you're not prepared, it becomes complete panic. And if you look here, there's just one mistake after another. Blindly bringing clips in, they're not under any control. They don't have good visualization. This is not how you deal with a rupture. And so I'm glad I've kept this all these years because it's a perfect example. And you can see how they completely lose control here. So you have to anticipate that this can happen at any time. The point is, don't panic. Take your own pulse first, as they say. The patient is not going to be hurt by that bleeding. The patient's going to be hurt by your next move if it's the wrong move. And if you're freaking out because of the amount of blood, look outside the scope. It's actually not as much as you think. And so I like to think of it in terms of 3 time points. Clearing the blood to see the proximal vessel, getting proximal control, getting distal control, and then finishing the aneurysm by either putting a pilot clip or doing your final clipping. And you have to be prepared to use different techniques. Sometimes simple coagulation can work of a small rent. Other times, you need to really arrest the circulation with temporaries everywhere. Don't forget adenosine. In a real bad situation, that might save you because it will stop the blood flow, and then it doesn't just come back like a switch. It ramps up slowly as the heart rate starts to recover. So it gives you a good minute of control to get things under control. So here's an example. Ruptured MCA aneurysm, doing the Fisher split, and you'll see now the sudden flash. Boom, sudden startle. No panic. You ask for your temporary. I don't throw it on. I'm waiting. All right. And I need a better sucker. So I tell my nurse, give me the bigger sucker. We time it. 1, 2, 3. She switches it into my hand and now come in with the larger sucker. Again, I'm not blindly putting that clip on. I'm going to wait until I see clearly the glimpse of that M1. There it is. I'm starting to see it. And now when I'm sure I have it in good view, I will put my temporary clip on the M1. That slows things down. So I now have achieved that proximal control. Next will be the efferent control. And now this really slows it down, and now I can see what's going on. So now that I have it under control, now it's still going to ooze a little bit. That's okay. Now I can see where the aneurysm is, and I put my pilot clip on. That gets rid of the bleeding point. Now it's back to being an elective case. I can take my temporaries off, reperfuse the brain, and then finish the actual clipping as if it were just a routine case, and you're done. So just, again, you have to be prepared for the intraoperative rupture and think of it in that way. So, surgical pitfalls with MCAs, not having proximal control. A common one that I see is the fear of dissecting the aneurysm completely. You really have to see it all the way around. It is amazing how many times you can get into trouble by leaving it adherent to part of the brain, not seeing it all the way, and there was a small branch that you may not have occluded with the clip, but the way the clip landed, it kinked. Or because the aneurysm was still stuck to the brain, it rotates once the clip is on, and it kinks a perforator. This happened to one of my partners, and he couldn't understand why the patient had, perforator stroke post-op, and it was precisely that reason that after the clip was on, the aneurysm was still adherent to the brain, and it rotated and shut down those vessels. So you have to be, meticulous about seeing it completely. If you see thrombus and atheroma, be aware of it. You may have to open it. Again, the devotion to the perfect clipping can sometimes get you into trouble as well. Learn to recognize that voice in your head that says, this is good enough. I'm just going to touch on this just because I was part of the title of my talk. But Giuseppe, tell me if you need me to stop at any point.
No, go ahead.
Along came this, the coils, or the old slinky. It was a toy back in the 1960s. I like to laugh that this slinky found a new purpose, and it evolved and became the new treatment for aneurysms. And so my practice over the last 15, 20 years up in Boston, I'm now in North Carolina, but up in Boston, this is what my practice evolved into. Patients that had had multiple previous treatments from an endovascular standpoint that now came to me. So here's an example. This should have been clipped. This was a ruptured aneurysm treated at an outside institution. They did that, assuming that this was a good outcome. This is terrible. Then they send her to me and say, we don't have anything more we can do for this. So what would have been a straightforward aneurysm to clip now becomes this mess. And so here I am, fissures open, temporary clip everything, open the aneurysm, don't pull the coils. All they do is unravel and become very sharp. You have to cut them up and remove them piecemeal. So once the coils are out, this origin to the M2 was partially occluded. I had to endarterectomize it, get some back bleeding, make sure everything's flushed out, and then it becomes a matter of reconstructing. And again, I put cotton all over the place before cutting those coils because they can float away and you end up with pieces everywhere. So now it becomes the geometric puzzle. First clip, get the temporary off, then gradually continue the reconstruction with other clips, taking them on, off, taking the temporaries off, repositioning until I get the result that I wanted. And then checking the flow afterwards once it's all done, making sure it's the same as it was before I started, and then finally the ICG run. And so that aneurysm is now properly taken care of. But this was a much more difficult, risky procedure for the patient than had it been treated properly the first time with clipping. So this is now the new game in town. You know, everyone's all excited about this. But when you really look at the papers, and I know I love this, Adam's one of my best friends, but 53.8% complete aneurysm occlusion, as effective currently available therapies and markedly safer. That to me makes that statement is an oxymoron. If I only occluded 53.8% of an MCA aneurysm, they would take my board certification away from me. To achieve that and then claim that it's as good as current available therapies is ridiculous. Another paper, 52.9%. And again, it's the elephant in the room. No one wants to accept. And then in 2021 at the Sun meeting, you know, Pascal Jabbour presented that, oh, we've gotten better. Now it's 85% occlusion with all the different. Again, if we are clipping an aneurysm and we're leaving 15% behind, we don't consider that a good outcome. And so, you know, these are the issues. So I looked at my own personal series. I went back to look at specifically my unruptured elective MCA aneurysms and tried to look at their follow-up and angiograms and so forth. And basically, I had 172 aneurysms in 163 patients. 169 were clipped, 3 were wrapped, 3 required bypasses, 9 were previously coiled and, you know, had incomplete treatment and so forth. I'm not going to belabor this. This is kind of the series, but let me just get to the final result. So basically, I achieved essentially 95% complete occlusion. If I exclude the wrapped aneurysms, it's a 97% complete occlusion with clipping. 3% roughly had some residual dog ears and so forth. These were the major complications. I had a 1.2% death rate, a 6% overall stroke rate. And essentially, this is the all death and stroke. And you can see really the larger and the more giant complex aneurysms were the ones where we got into trouble. But overall, good outcomes. So, you know, I'm going to publish this because I think now with the web device and everything that's going on, you know, it adds to this literature that I think serve as benchmarks. So when they're claiming that we can treat them with a web and it's as good as that, here's the benchmark they really need to say it's as good as before they can claim that 52% occlusion rate is acceptable. So again, you know, managing MCA aneurysms overall can be done well. You know, these are some of the tenets and so forth. At the end of the day, I feel sometimes like I'm screaming into the wind. Is it really going to matter? You know, has that train left the station, as they say? Time will tell. And with that, I'll wrap up. Thank you.
Thank you, Carlos. Great as usual. Professor David, somebody I admire for his skill, but also for being always brutally honest. And few points that I like to re-emphasize is how much information you can get from that AP view of the angiogram. The length of the M1 stem tells you a lot about potential involvement of lenticular striate from around the neck of the aneurysm. You showed us beautifully. There was I think it was an anatomical picture where you showed us if the stem is short, lenticular striates often arise from the proximal M2 and run parallel to the M1 segment to go to the anterior perforated substance. So very important point to stress how much information you can get by just looking at that straight forward AP view. The other thing is the preparation of the aneurysm, and I cannot agree with you in terms of when you have the luxury of being able to expose circumferentially that aneurysm, really gives you the best chance to do it safely. And also emphasize that at least when I started, as soon as I understood the anatomy, there is that impulse, say, well, let me put the clip and be done. And instead, you gotta do your homework. I found, and you showed it also, and you mentioned, really once you get a sense of the aneurysm and you have control, remodeling the sac more than the neck, remodeling the sac with short bursts of low power bipolar often allows you, when the aneurysm seems to be stuck to the pia, allows you to retract that sac and then brings that arachnoid plane into clearer view. And many of these cerebral artery aneurysms nowadays, even if the patient is healthy, but my experience is that if the patient is older than 50, you are going to find some degree of atheroma at the level of the neck. And there it becomes a fine balance between being a perfectionist, as you stressed a few times, and also never always remember you cannot count on that. But if your clip is not perfectly at the neck, but there is atheroma, the thickness of the atheroma will flatten the walls of the level of the neck, that even if from the outside looks like there is a residual, there might not be a residual in terms of actual residual flow. So Carlos, thank you so much. As usual, you deliver a great presentation, perfectly in the spirit of what we are trying to do here.
Thank you.
I'll
Sir,
pass the
Sir,
yes,
do you mind
Michel,
if I have a question at
please go ahead.
Okay, I didn't I didn't heard about much about veins. Sometimes it is difficult to expose the MCA, not only because of the configuration of the Sylvian fissure, but also because of the veins. Do you have any comments on that, and how do you try to anticipate this problem?
Yeah, again, studying the venous stage of the angiogram will kind of prepare you. And again, this is variable. You know, sometimes you open up and the fissure's wide and the veins are out of your way, and there are other times where there's 3, 4 of them all bunched together. You know, in general, I stay on the frontal side, but there have been times, again, you have to modify depending on what you find. There have been times where I've had to dissect between veins. And at all costs, I really tried to preserve veins. I do not take them. I had an old partner once who used to argue that he had never met a vein he couldn't take. That to me is just sacrilege. I try to preserve them. There are sometimes crossing veins in the fissure, and those are generally safe to take, even though I try not to. There are times you are forced to. There's just no way around it. And again, this lends itself to what I was saying earlier. I split as much fissure as I need. The temptation, especially early in your career, is to just split it widely from all the way. But sometimes the aneurysm is very distal, or you have a very good view of it with just a small portion of the fissure open, and you might avoid having to then struggle with those veins in the situation. But in general, I try never to take veins, but there are those crossers that sometimes you have to deal with, and they may be safe to take. Yasuhiro says they are anyways.
Thanks to having emphasized this point. I think it's...
I like to also stress we have heard 2 presentations from highly skilled colleagues. And for the younger participants, it's important there is, you know, some prefer to do a targeted Sylvian fissure splitting. Others prefer to, very equally experienced, prefer to have a wider exposure of the Sylvian fissure and the middle cerebral artery. So it's important for the younger colleagues to know about all the options and then try to make your own technique. But at the same time, realizing that what you hear as highly experienced operators. So at the beginning, Evandro always used to stress, use all the space that you need. And the same thing, it applies a little bit to the veins. The classical teaching is that arteries don't cross the sylvian fissure, so you can split, and the artery might belong to frontal or temporal, while veins might cross the sylvian fissure. And in order to gain room, you can often skeletonize and free the arachnoid around the vein so they are easier to mobilize. But there are situations that where you need to take a vein. If you do that, I would recommend to do it as much as possible in the late phases of the sylvian fissure splitting, because as Carlos mentioned, veins are there for a purpose. It is true that you can often safely take some veins in the cross the sylvian fissure, but I guarantee you that the moment you do that, then the consistency of the brain changes. The PL surface starts bleeding, while before you could easily mobilize and use the arachnoid plane to protect you. So mobilize as much as possible the veins when they are on the way. Do not sacrifice safety of clipping and exposure of the neck when there is a bridging vein that you can take. But if you do that, do it after as wide as necessary splitting on the sylvian fissure, because the moment you take the vein, I tell my residents, the operation changes. Great points. Thank you, Michelle. So we have the last but not least important presenter is our colleague from Fudan University in Shanghai. They have incredible experience in managing complex aneurysm of the middle cerebral artery. They have published extensively. So Professor Pexi Liu is going to give us their overview on this very important topic. And I do agree with Professor David. I'm a strong proponent of endovascular techniques, but I do agree. And actually, I feel much strongly today that in the past that microsurgery has a very important role in the management of many aneurysms that we see today. So it's very important that we all learn from each other as we are doing this morning. Professor Liu?
Okay, thank you. And can you hear me?
Yes, I can hear you very well.
Okay, and the professors and colleagues, and it's my honor to introduce some experience on the topic of the surgical management of the complex MC aneurysms on behalf of the Professor Zhu. And something wrong with my PowerPoint. Sorry. And in China, and most young colleagues now deal with the regular unruptured aneurysm using the interventional therapy now, because it's fast and minimally invasive. And from the 2002 and to the 2023, there's many clinical trials want to discuss whether the craniotomy or intervention therapy is better when dealing with the aneurysms. And what about the MC aneurysms? And several years ago, we think the best strategy is to perform the clipping using the craniotomy, and especially for the hematoma over 50 milliliter, or the subarachnoid hemorrhage with vascular spasm, or the elder patient who cannot afford the dual antiplatelet therapy. And now in 2022, there's also a clinical trials, and we are also looking forward to the result of the MC aneurysm surgery. And the world is changing, and just as I showed, the web and the contour and the next the many interventional device usage and put the bifurcation aneurysm forward. And also, this is the Piconers 1 and 2, and used in the bifurcation aneurysm implant. And anyway, the anatomy of the Sylvian fissure in the MCA is very important, and some young patients think it's easy, but the anatomy variation is very difficult. And about 11 years ago, and Professor Zhu and I has published an article discussed the complex middle cerebral artery aneurysm. And we set a new classification based on the angio architecture and the surgical strategies. Until now, about 20 years later, and we also published the 3 articles also discussing the MC aneurysm strategy, surgical strategies 1 year ago. And somebody says the aneurysm, MC aneurysm is easy, but I think it's hard, especially for those complex MC aneurysm. And we also want to illustrate this topic from the classification based on the angio architecture. And this is the M1 segment aneurysm. I also want to begin with a case. And it's a 26 years old male patient, and the chief complaint is lower limb weakness for more than 3 weeks. And from the CTA and DSA, we see the left M1 segment big aneurysm. And also we can see the CT scanning, we can see a lesion located in the left Sylvian fissure, and also the MRI T2 image, and with the mixed signal lesion. And this is a picture during operation because it's large and also located in the left MC-M1. We perform the trapping, and we use the radial artery as a graft to perform the STA-RA-MC bypass. And now the patient's fine, and this is a post-operative CTP. And from the perfusion, we see the left hemisphere showed the low perfusion. But the patient was fine, and we also found the slight right foot weakness, and the muscle strength reached grade 5 minus and no aphasia. And this is the post-operative DSA. We review it, and the bypass was patent. So now the bypass moved from the ECIC to ICIC. There's still some obvious advantages of the ICIC bypass. For example, the shorter bypass graft for the fluent blood flow. And also we can avoid the muscle flap and the bone flap affect the donor and the graft. But there's also some limitations. For example, in IC complex aneurysms, the EC-IC bypass showed more advantages than IC-IC bypass, and the IC-IC bypass could not be performed in some aneurysms. Just for example, the PCA-P3 segment aneurysm or the basilar arteries aneurysm. And what about the MC complex aneurysms? I searched in PubMed 1 year ago, and there's most of the neurosurgeons could choose the ECIC bypass, and seldom for the ICIC bypass in the complex MC aneurysm. Several years ago, we performed several bypass based on the ACA1 as the bypass donor. There's still advantages. The first is the interposition short graft. Only 5 centimeter RA could be used as graft, and no anastomosis time limitation for RA1 and two-side anastomosis because of the ACOM artery composition. And there's some limitations for the A1 as donor. The first is the experienced anastomosis technique was used because the corridor of the operation was very narrow and deep and deep. And also some perforators will sometimes from the A1 segment, and sometimes the ACAM artery composition assessment before operation was needed. And this technique was not we just performed the first time. In 2018 and 2020, and Professor Lawton has published two articles to show this technique. And after we performed 7 cases, we also published two articles to illustrate this technique. And let's move to the case 2. And this is a application of the A1 donor bypass in a ruptured aneurysm. And it's a 27 years old female patient, and chief complaint is sudden onset headache and vomiting 1 month prior. And in the local hospital CT report, we found the ICH. And after admitted in our hospital, we reviewed the CT, and most of the ICH was absorbed. And this is the CT scanning. We see a little high density lesion was located in the left Selvin fissure. And this is a high resolution vessel wall MRI. And we found the aneurysm wall was enhanced. And this is CTA reconstruction. We can see the left MC-M1 segment dissection aneurysm. And we also review the CTA. And this is left ICA and the AP position and the lateral position. And this is some pictures during operation. And we use the radial artery as graft, and we perform the end-to-side anastomosis to the M3. And another side of the radial artery, we perform the RAA1 end-to-side anastomosis. And this is a bypass. And the ICD showed the bypass was patent. And this is a short video, and because of the time, let's skip it. If we have enough time, I will show it. And after that, we perform the aneurysm trapping. And also, we perform the intraoperative DSA. The aneurysm was better, and the bypass was patent. And this is the post-operative CT scanning. And also, let's move to the another bypass. Just as the many professors mentioned, the STA-MC bypass is the most classic and the most effective method in the MC aneurysm surgery. And let's move to the next case, and it's STA-MC bypass used in a recurrent aneurysm. And it's a 19 years old patient, and chief complaint is sudden onset headache and vomiting 1 day ago. And during in emergency department, and the Glasgow score was just 8. And we can see the CTA, and it's aneurysm with hematoma. And in local hospital, the neurosurgeons perform the aneurysm clipping using 2 regular clip. And during follow-up, 1 year later, and we found its recurrence. So we perform DSA, and this is AP position and oblique position. And for this patient, we perform the aneurysm trapping. This is an illustrative figure. And this is the first time, and we found the recurrence. And in the second time, we performed the aneurysm trapping, and we used 1 STA to perform the STA-MC bypass. And this is a post-operative CTA, and this is a bypass. Another patient's fine. And this is the STMC bypass used in the recurrent aneurysm. And also, it can be used in the graft-related complications and can be used as the salvage therapy. And this case showed a 58 years old male patient. And the chief complaint is aneurysm found by health check 1 month ago, and no positive findings in physical examination. Then from CT scanning, we found the right MC aneurysm, and this is a high resolution vessel wall MRI, and this is a contrast image. We can find the mixed signal intrasac, and we perform the DSA. The DSA shows the right MC M1 segment aneurysm, and this is 3D reconstruction. And this shows the right ECA and the 2 branches of STA. And we also want to perform the A1 RA and 2 MC bypass. And this shows the A1 to RA and this RA to M2. And during operation, the ICG was fine and the bypass was patent. Well, we performed the intraoperative DSA. The patent was occlusion. The bypass was occlusion. So we back to the operation field. We found the thrombosis in the anastomosis point, and we remove it and perform the anastomosis again. During operation, the ICD shows the bypass was also patent. Well, when we perform the intraoperative DSA, the bypass was also occluded. It's weird. So we have to perform the STMC bypass. And after that, this is the last time intraoperative DSA. And this is the ECA. And this is a post-operation CT scanning. We also found some ischemic stroke located in the right basal ganglion. And this is operation video. Well, after 3 months of follow-up, the patient was fine because of composition from other vessels. So sometimes the STMC bypass can be used in the graft-related complications and also can be used in salvage therapy. So what about the bifurcation aneurysm or the M2 aneurysm? Let's move to the next case, and it's a 60 years old female patient, and the chief complaint is intermittent dizziness for 1 month, and also no positive findings in physical examination. And this is a pre-operative MR and the MRA, and we found the right MC bifurcation aneurysm, and also it's we found the mixed signal intra aneurysm sac. This is DSA and the 3D reconstruction. We can see the 2 right M2 branches derived from the aneurysm sac or even the neck. So we set a strategy. If we can directly clipping or perform the aneurysm morphy, we must use the intraoperative DSA to confirm there's no remnant. And if we cannot perform the direct clip or aneurysm morphy, we need to perform bypass. This is a picture during operation, and this is aneurysm. And we perform the proximal occlusion and also 2 branches of M2, and we punctured the aneurysm. And we use 2 regular clip to perform the aneurysm clipping, And this is the ICG during operation. We found the aneurysm was clipped. Well, during the intraoperative DSA, we found a remnant here. And this is 3 positions to show the remnant. So the intraoperative DSA is very useful. So we add 2 milliclip, and we review the intraoperative DSA. The aneurysm was totally clipped. And we also show 3 position of DSA. Another patient fine, and also a short video. And a similar case, 62 years old patient, and the chief complaint is intermittent dizziness and headache for 2 weeks. It's similar, right? The aneurysm was located in the left MC, M1, M2 bifurcation. And also 2 M2 branches derived from the aneurysm neck. And this is a high resolution vessel wall aneurysm. And the more mixed signal intra aneurysm sac. So we also cite preoperative strategy. Just like the previous case, we want to perform the aneurysmorrhaphy or perform the directed clip. If failed, we need to perform bypass. But we can say this patient's M1 and M2 length was enough. So we have the third strategy. If we can, we could resect and remove the aneurysm and perform the reconstruction of the bifurcation. So this is the pictures during operation. And this shows the aneurysm and M1 and 2 M2 branches, just like this. And after we remove the aneurysm and we perform the end-to-end anastomosis first and leave part of the anastomosis point and then perform the N2 side anastomosis to reconstruct the Y fashion anastomosis. And this is during intraoperative DSA. And this is the AP position and the lateral position. And this shows the anastomosis point. And we also detect the blood flow of the M1 and the 2 M2 branches. And this is 1 month 1 month after operation. We review the CT and the MR, and this is T2 flare and DWI. And this is the CTA. The triangle shows the arrow shows the anastomosis point. Another patient's fine. So it's 2 similar operations and bifurcation aneurysms, but the bypass strategy was totally different. In some cases, we must perform the STMC bypass prior. Just like in this case, and it's a 64 years old female patient, and chief complaint is severe headache for 5 days. And the CT scanning shows the high density lesion in left salivary fascia, and this is MR. We found the mixed signal lesion. And before operation, we also performed the DSA, and this is left ICA from 3 position. And this is a 3D reconstruction. And we can say it's M1, M2 bifurcation and near the M2 MC aneurysm. So this is pictures during operation. And after we split the salivary fascia, we found the aneurysm neck and the dome was with severe atherosclerosis. So we want to perform the direct clip, but we failed. And then we want to preserve 1 M2 and M1, and to perform the M3 side-to-side anastomosis first, just like this. but we still failed. We cannot preserve the bifurcation. So we have to perform the double barrel STMC bypass first to guarantee the M2 distal blood flow and resect the aneurysm. Well, fortunately, and the length of M1 and M2 was enough for the side-to-side anastomosis. So under the protective STMC bypass, we perform the side-to-side anastomosis. And this is a video, short video. And this is a post-operative DSA. And now the patient's fine. There's no hematoma and no the infarction. So what about the M2 bifurcation to M3 or distal? Maybe the proximal occlusion works. The next case is a 45 years old male patient and chief complaint is repeat headache for 1 year. And this is a CT scanning. It's a very large aneurysm with calcification, maybe with thrombosis. And this is MR with mixed signal lesion. And this is DSA. The DSA shows the right MC distal, M3 distal aneurysm. So we draw an illustrative figure to show the strategy. And the aneurysm neck was located in the M3. So we just performed the proximal occlusion. And this is pictures during operation and the post-operative CT scanning. And this is post-operative DSA. Another patient's fine. The composition was enough for this patient, so we just performed the proximal occlusion. But what about the complex, extremely complex MC aneurysms? Just like this case, it's a tandem aneurysm, MC aneurysms. And in this case, we performed the staged surgery. This is a 57 years old patient and with chief complaint of sudden headache for 1 day. And in physical examination, the Glasgow score was 13. And the bilateral muscle strength was grade 5 minus. And this is pre-operative CT scanning and MR. And we can see the high fissure grade subarachnoid hemorrhage. And we found 2 left MC aneurysms also with mixed signal. And this is first aneurysm, and this is the second aneurysm. We found the mixed signal intersect. This is a pre-operative DSA. And this is left ICA. We can see it's a tandem MC aneurysms. And one is from ICA and one is, it was located in the left MCA. And this is left ECA. We just mentioned that we also we always need to preserve the 2 branches of STA. And this is the right ICA. After compressed the left ICA, we can see the composition from the contralateral ICA. This is a left MCA M1 segment aneurysm. And we also perform the 3D reconstruction to show the aneurysm structure clearly. So the before operation, and we perform we set a strategy, and it's a very complicated tandem aneurysms. So in first stage, we need to perform the ECRA MC bypass like this to reconstruct the distal left MC blood flow. And meantime, we will perform the left ICA occlusion. And in the second stage, we want to perform the aneurysm trapping using the interventional calling. So this is a picture during operation. And we split the cell vein fission and expose the aneurysm and the M1 and the 2M2. And we found the obvious atherosclerosis in the normal artery. We found the anastomosis points and to perform the RA and M2 bifurcation and to set anastomosis. And in the neck incision, we expose the ECA and also found the anastomosis point and perform the RA to ECA anastomosis. And after that, we perform the ICA ligation and a short video. And this is the post-operation CT scanning. During operation, we remove the bone flap to avoid the post-operative edema. And this is a post-operative CT scanning. The bypass was patent, while the left MCM1 aneurysm was also there. So about 9 days later, and the patient was fine, and we review the DSA, and this is the right ICA angiography and the lateral position. And from the left ECA, we found the bypass was patent, AP position and the lateral position. And we also merged the two 3D reconstruction to show the structure more clearly. So after that, we set the right ICA approach using guiding catheter and using one echelon 10 microcatheter to raise the left MCA aneurysm across the ACAM artery complex and set several coils to perform the trapping. And this is a post-operative DSA. And now the patient's fine. And we have several take-home messages. And the first is MCA aneurysm surgical strategy must be based on the location. And every MCA aneurysm was totally different. So the individual vascular structure must be judged before operation. And for us in our hospital, the high resolution vessel wall MR will be performed before the on-rupture DSA, and especially for those complex DSA. So the HRMRI always show the more information about the aneurysm wall structure. And the next is for our young colleagues. The low brain pressure means better operation corridor, and we always need more anastomosis space. And just as the cases we show, the hybrid operation, the intraoperative DSA, always can ensure there's no remnant and the bypass patency. And the next message is the STA should always be preserved for salvage therapy. And when the ICS bypass failed, it's very useful. And the last but not least, for the extremely complex the MCA aneurysms, the staged surgery maybe is a better option. Okay, thank you.
Thank you for this comprehensive overview and complex cases, but also nice example on how with using all the tools that we have available, you can, with imagination, resolve a lot of these very complex puzzles. I leave the stage now to Professor Bojanowski to wrap up the discussion, show some cases for discussion, and then conclude the seminar.
Do you hear me? Yes.
Yes, yes.
Can you see my slides?
If you can share your screen.
Done. Is it, do you see it? Do you see my slides now?
No, we don't see your slides.
Mamma mia. I share it.
Maybe if you can unshare and then try to share again. And
desktop. It says allow Zoom to share your screen, and I say yes. Okay, open your system preference. Is there a reason why it's not working?
Imad, if you're still on the
Yes, sir,
line,
I'm here, but I think it's the privacy from his computer, I guess.
okay.
Oh, I'm surprised because I have already done that with that computer. Okay.
You can try if you can email me the presentation. I can see if I can open on the screen and then I can advance the slides for you.
Okay, I'm going to do this right now. I will use WeTransfer maybe because it might be a lot of the videos might be heavy.
In the meanwhile, I'll scroll through the chat and see if
sorry about that. Huh?
There was a question about how to dissect and open adherent sylvian fissure in a patient with years old and past history of bleed. And I think Dr. David mentioned that there are situations, especially in young patients, and as you proceed from distal to proximal, more proximally, where the fissure can be quite tight, but in that situation with the Yassergel technique from the inside out, once you have a corridor down, you can gently put traction on the temporal and frontal lobe and identify and proceed with under high magnification. In a patient with the prior history of bleed, it is true that the arachnoid is thickened and the planes are stuck, but sometimes that also acts as a protection because the thicker arachnoid at times protects you while dissecting around the vessels and the aneurysm itself. Carlos, do you want to add some other there is I remember you always used to talk about the water dissection technique, and that's actually very helpful. It's just after you open a small nick in the sylvian fissure with the syringe, inject under relatively high pressure some saline. It helps to open up the places.
Yeah, it helps, in terms of blasting the arachnoid apart from each other. But what I had answered the person directly, but basically, when some fissures, let's be honest, are just impossible. Even Yassergel, if you look at his classification, he called the post-meningitic, the post-subarachnoid, what he called a grade 4. It's essentially almost impossible to split cleanly. And I think what you were saying is probably the best technique. Sharp, get deep inside, try to find that plane and separate it. But I think at some point with some of those more difficult ones, you're just going to have to accept that you're going to be subpeel at some level. And I tend to err on the side of I'm going to be subpeel, try to do it on that superior temporal gyrus, which, Roberto Heros, one of my mentors, used to argue that that was a nice way to split the fissure, to go through the superior temporal gyrus, to get deeper and then work your way out from there. I prefer to just preserve brain, obviously, but in some of these difficult situations, that's just, I don't think it's avoidable.
Giuseppe?
Yes.
Yes, soon you will receive the presentation via WeTransfer in your email.
Okay.
It's 90% now. And it's done. You should have received that.
Okay. Yeah, I have here my email open. As soon as I receive, I'll when one other comment is the previously coiled aneurysms. Professor David shows nicely the technique of opening the aneurysm and removing the coils. If there is an adequate neck, and we can discuss what that might mean, I found it very useful in those situations to direct clip the aneurysm using a fenestrated clip, even when there is a coil right in the vicinity of the neck. I don't know if you have also.
Yeah, so I guess I didn't make that point. My primary gestalt is not to remove the coils. So I always try to clip primarily and just ignore the coils. But as you noticed, frequently there's a shelf, they won't close, or they're going to push you down to the point where you're occluding the parent vessel. So in those situations, then I open the aneurysm. And what I do is generally just mobilize enough, get them away from the neck and clip. There are some situations where I have to remove them completely, but I try to avoid that if I can. So I agree with you. Just do what you need. And if you don't need to, just leave them alone because it's actually better.
Now, you also mentioned that you really use liberally temporary clipping.
Yeah.
I've always been, I always wonder, because often when you remove the temporary clip, you see that on the vessel there is the impression of the temporary clip. And have you ever had any problem where besides the length of the? It's surprising how really you don't have any problem besides the length of the temporary clipping, by just the use of the temporary clip, even adjacent to perforating vessels. Because let's face it, when you do MCA aneurysm, the temporary clip, there are always lenticular striates that are adjacent to that temporary clip. So
yeah, I've not had any issues with the vessel being injured by the temporary clip. But I think the only times I've gotten in trouble were, frankly, early in my career when I was overzealous and I left them on too long. And I had some ischemia. You have to kind of respect the numbers that Hunt Bajer and Duke put out years ago. They really do hold. And of course, keep the blood pressure up and do your neuroprotective strategies. And I always try to avoid any perforators kind of being incorporated. But yeah, other than the length of temporary clipping, I've not had any issues with the clip itself.
I guess, Giuseppe, your main message here is, again, exposure is very important. And before you replace a temporary clip, we have to have a well-exposed MCA, and we have to look for these perforators. I guess this is your main message here, no?
Yes. And continuous temporary clipping versus intermittent. Do you have any strong feelings?
If the clipping is going to be prolonged, I'm realizing, okay, I'm on here a little bit too long, I'll take it off and let the brain reperfuse. In fact, that was my research project when I was a resident in my research year. I did a study on rats where I had 60 minutes of continuous occlusion of an MCA versus 6 10-minute periods with 5 minutes of reperfusion. In my simple little study on rats, I showed significant difference of protection, less volume of infarct with the intermittent than the continuous. So I've always just subscribed to that. Again, the data is, soft.
And in your practice, how do you decide? How do you advise patients in terms of indications for surgery versus consideration for endovascular therapy for an MCA aneurysm
For an
specifically, since
MCA,
this is
I'll be honest with you. Like I said, I'm not terribly impressed. So age, comorbidities, general health. Um, First, does the aneurysm need to be treated? I have many elderly, unhealthy people who come in with small aneurysms. I tell them, leave them alone. There's nothing to do here. If the aneurysm needs to be treated and they're very unhealthy and you really worry that you can't get them through a craniotomy and recovery in a reasonable situation, then I'll speak with my endovascular colleagues, or in a rupture situation where poor grade, unhealthy, old. My new patient population here in North Carolina tends to be very unhealthy. And so I've had my colleagues partially coil and see how the patient does, and then I can always go back and fix it, later. That's kind of my view. And me, I'm not a zealot. I am a true, I work well with people who do endovascular, and I've worked with Insub Choi and so forth. I think it has a role. In the MCA specifically, though, I still feel that is a surgical aneurysm. But everything has a place. So I think you have to individualize it based on all of those factors.
Michelle, I'm sorry. They are telling me that I've not received the email yet, and
I have the message, the opposite message. I have the message here that you have received it. Is it now the
well,
email?
there is let me see. I'm on my phone and on my computer, so I will eventually will, but there is a lag time, especially if there are attachment with the Mayo firewall, I think. So, but we can. And we have gained quite a bit of experience with clipping previously coiled MCA aneurysms. Have you had any experience with the new entity, the previously web? I've heard some colleagues at meetings saying, "Oh, the web is very compressible." We clipped our first web recurrent, and I didn't find it as easy as some colleagues had made it sound. But basically we face the same issues that you face with previously coiled aneurysm, is that you have this rigid structure
Right.
close to the neck that really complicates things. We were able, again, with the fenestrated clip, tandem fenestrated clip, we were able to manage. But I had been told, though, it's very compressible, but that was definitely not our experience.
I'll be honest with you, I've not had a web yet. I always worry about those situations. Though where I have encountered, the difficulties is with the flow diverters, the pipelines and the surpass being in a vessel. I had an ICA bifurcation aneurysm. I think I've shown it to you, that was initially coiled, recurred. Then they put a pipeline and the patient got in-stent stenosis and the aneurysm was still there. And basically Waklu had no more options and he gave it to me. And the pipeline went from the carotid at the skull base all the way up to the MCA. There was no way to have temporary control. So I had to open the neck just in case, because you don't want to put a temporary clip across a pipeline or a flow diverter because it won't reopen. It'll be done. And what struck me, I did a bypass to protect myself, opened the neck, and then I was able to mobilize the coils and get the aneurysm clipped. But what struck me was the appearance of the blood vessel itself. It looked diseased. It's interesting. The outside looks like a necrotic yellow friable vessel. And that argument about, the healing versus the degradation after you put a flow diverter, you can actually see that in the vessel wall. And I guess that's why if the degradation beats the healing, you end up with those ruptures that we saw early on in the experience. But it struck me how the vessel looked.
Michelle, you have any experience with clipping previously aneurysms previously treated with the web, or
Not with the web.
Mhm.
Not with the web.
Any advice you have for dealing with the previously coiled aneurysms? Or?
I think when the aneurysm is small and there is a small recurrence, I usually wait, especially if the patient have never bled in the past. I just make sure that before I suggest any surgery, if I can put a clip on that aneurysm, because sometimes you don't need a very large neck in order to put a clip in a previously coiled small aneurysm. For large aneurysm, it's another problem, because you might have a recurrence with the coil at the neck, and this is more difficult, and everything has been said. I think you need then to open the aneurysm to remove the coil. And I agree, as less as possible, just what you need in order to put your clip. I operate a few patients with very large aneurysm, including basilar aneurysm with a lot of coils and with these inflammatory reaction compressing the brainstem, or with brain edema, especially with the very good results when you remove you open the aneurysm, you remove all the coils in this situation, and then you close the aneurysm. I had this week a special case, a patient with, I don't know if you ever heard about the NICE syndrome. The patient with this, I think it's nickel allergy.
Mm-hmm.
Okay, so the patient has this brain swelling, intermittent brain swelling, according to the doses of steroids, and it's very difficult for this patient. It's very difficult to treat, and the problem is that I cannot remove the aneurysm without sacrificing because there is no recurrence of the aneurysm. So without sacrificing the vessel and maybe doing a bypass, but I have to think about that because it's a very complex ACOM aneurysm.
Yeah, you're referring to this condition of non-ischemic multiple enhancing brain lesions that we see likely not that frequently in patients after endovascular treatment. And the question is, though, if those lesions are related to the presence of the coils, or they are a sequel of the original procedure where some microembolizations occurred, and which led to, we have definitely encountered a few of those over the years. And you're correct, you stop the steroids and they recur and they become they'll become they
Yes.
become symptomatic. So let me do this. I'm forwarding an email from one of my students, and we can see if we can, because I still do not have, but I sent you an email with the link that you can download directly to a Mayo computer.
I'm really sorry about that.
that's fine. It's it's one of the issues of being on online, but it's
Drop link, is that you? Yes. So I just can, yeah. Okay.
Carlos. Any it looks like for in terms of complex aneurysms, we have moved over the past 20 plus years away from high flow bypass in most cases, I would say, especially for middle cerebral artery aneurysms, and learned that often the STA is enough in many situations, especially when you are trying to replace a single branch. What has been your experience? How do you think about that? And
Yeah, I think this comes from Fadi. Fadi showed all the flow studies that a good STA is enough. It used to be when I was a resident, they would say, oh, the maximal you'll get from an STA is 30 cc's a minute. And the reality is you can get double, triple that sometimes. You're right. Early in our careers, it was the vein, then it was the radial artery. I've gotten to the point where an STA is plenty. The only times I've used high flow nowadays is if I'm taking the carotid completely and, the patient fails a balloon test occlusion. But I think the STA, a good STA is plenty. And I think Body really laid out the groundwork for that.
And another point that, again, I wanted to reemphasize from your presentation is that we have so many tools nowadays that allow us to watch for perforator compromise of flow. I train, I'm old enough that I trained at the time where the intraoperative Doppler was the only tool. So I know it's not perfect, but I can, I'm usually able to tell, but it's important if you do that, you have to, as you mentioned, um, you have to get a baseline before you maneuver or you put a clip. Get an insonation with the Doppler, get your baseline ICG fluorescent. If you are lucky to have the flow probe, you can measure the flow, but it's critically to do it before so you have a baseline. And I must say that with the Doppler, after so many years, I can usually tell if the vessel might be open on ICG, but I can't I can tell. But that's a point to reemphasize, and it's funny, over the years to realize that some of the critical things that we all have learned through trial and error quite often are well known to the masters. It's just that it's an emphasized comment or a single sentence. And, listening to your presentation, there were so many pearls that, and that's the reason why I felt the importance to re-emphasize and repeating so that the younger colleagues, they can get the most out of this and don't have to go through the same motions that
Right. It's the
we have
nuance.
gone to, doing something, observing something, and then you go back and you read what he has written and say, oh, it's here, but it's one sentence.
Yes. It's the nuance that, you pick up as much as you can during training, but it's experience that teaches you, unfortunately, sometimes with bad experiences. One of my mentors said, experience is your last case, and it holds true. You learn from each and every one. And Spetzler used to say when I was a fellow, you would watch him do some amazing case and you would think, oh, I can never get to that point. And he would say, no, you're just not as good as you're going to be. And that's holds so true that you grow and evolve as you go through your career. If you're careful and you look at your results and especially your bad results and really ask yourself what you could do differently, we grow.
And like with aneurysms, and I mentioned before, I learned that when I started with my practice, you go through the operation, the exposure. There is a point where you think you have enough and you are tempted to put a clip. And those are the times where now I realize it was because of inexperience. I end up with a bad result, and the importance, of doing your homework, exposing, freeing that neck, even though you do take a chance, especially in a ruptured case. But once you have proximal control, it's critically important to have a full understanding, separate the arachnoid around the aneurysm, free the neck, and have a good view, especially where you know that perforating vessels are going to be. So let me see. If I open the folder, still cannot see it.
Something is, I think, it might be because of the hospital.
Yeah, the Mayo system. There are so many firewalls that there is always a significant lag, and I think with what happened yesterday, it's even more so. So that's fine. I think we can we are planning to do this on a monthly basis. We can reserve your cases for next time. I like to.
Okay. Again, I apologize for that.
It's we are lucky that we have your presence and your words of wisdom. I like to thank everybody, the participants, but particularly the panelists for their generous time. And once again, I cannot thank enough Imadullah for making all of this possible and for being here with us on a Saturday. Thank you very much.
Thank
Thanks.
you. Was fun.